Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello and welcome to this episode of Triage. My name is Richard Church and I'm a partner in the firm's Research Triangle Park and Chicago offices. My practice focuses on healthcare regulatory and transactional matters with a focus on the 340B drug pricing program and pharmacy-related issues.
And I'm Victoria Hamscho. I'm an associate in the firm's Washington, D.C. office, where my practice focuses on healthcare policy and regulatory matters, including matters relating to the 340B program.
Before we begin, we'd really like to welcome and introduce Andy Ruskin into our Triage series. Andy recently joined K&L Gates Healthcare and FDA practice and is a partner in the firm's Washington, D.C. office. Andy brings with him a wealth of experience helping clients navigate the 340B program, and we've worked with him collegially for many years, as well as with other Medicare reimbursement and compliance and APA litigation matters. So we're delighted that he's joined the firm.
Thanks, Rich, and I'm delighted to be here. As Rich mentioned, I reside in the firm's Washington, D.C. office, and as Rich also mentioned, I do a lot of work in the 340B drug space as well as Medicare reimbursement and compliance. Of course, 340B drug pricing issues at the current moment could not be more exciting, so I'm so glad to be with you all for this episode of Triage and also to call you guys my colleagues. In today's episode, we will provide an update on recent developments in the 340B program, including recent actions by drug manufacturers to limit contract pharmacy utilization of 340B pricing, and also to work with covered entities regarding new reporting requirements that they are seeking the support of the covered entities to implement. There are also some new legislative proposals in Congress that will press the pause button on 340B hospital eligibility requirements for the duration of the current public health emergency.
So we'll start with the contract pharmacy issues and drug manufacturer Eli Lilly's action. Recently, Eli Lilly issued a notice to 340B covered entities that is poised to have a material impact on the 340B program. Lilly issued a notice informing them that effective July 1st, it was limiting distribution of its erectile dysfunction drug Cialis to covered entities and their child sites only, and that covered entities will no longer be permitted to replenish to their contract pharmacy locations at 340B prices. As everyone is probably aware, the 340B statute requires drug manufacturers to sell covered outpatient drugs to covered entities at 340B discounted pricing. And Eli Lilly's notice, though, defies HRSA's longstanding contract pharmacy guidance, interpreting the statute to allow covered entities to replenish to contract pharmacies at 340B prices also, under a bill-to-ship-to model. Since 1996, HRSA has permitted covered entities to contract with these pharmacies to provide services to the covered entities' patients. Although covered entities were initially limited to using in-house pharmacy or contracting with a single contract pharmacy, that guidance had been expanded in 2010 to permit covered entities to contract with multiple contract pharmacies. And that has led to a large growth and expansion of the program as many covered entities entered into multiple discount drug arrangements with contract pharmacies to serve their patients in a broader area. In response to Eli Lilly's notice, HRSA recently noted that although its 2010 contract pharmacy guidance remains in effect, it is not legally enforceable. In this regard, HRSA appears to have elected to not take action against Eli Lilly to require them to replenish drugs to contract pharmacies, notwithstanding its prior guidance. In this regard, HRSA noted that unless there is a clear violation of the 340B statute alone, its authority to enforce certain 340B policies and guidance is limited. HRSA also indicated that without comprehensive regulatory authority, it is unable to develop enforceable 340B policy. This notice from Eli Lilly came just as HRSA had also uploaded its Federal Register notices, including its 2010 contract pharmacy guidance, to the HHS new guidance repository, which includes a disclaimer that the contents of the documents do not have the force and effect of law and are not meant to bind the public in any way. The big picture of this action is by defying HRSA's longstanding guidance and in light of HRSA's response that it lacks enforcement authority, the path would now appear to be open for Eli Lilly and other manufacturers to take similar action to exclude other 340B drugs from replenishment to contract pharmacies. This would have important implications for the 340B program and covered entities and would result in immediate disruptions and reduction in the size of contract pharmacy arrangements. Similarly, though, Lilly's uncontested action and HRSA's statements also mean that guidance applicable to covered entities is also now in question. In recent years, HRSA has increasingly taken the position that it lacks statutory authority to issue and enforce 340B guidance, and this series of events seems to solidify definitively that position. And so therefore, a likely response that we'll be on the lookout for is congressional action to move to provide greater authority to HRSA legislatively. With that, Andy, I'll turn it to you for your thoughts and other new developments.
So it shouldn't come as a surprise that in the same week that Eli Lilly announced its plan to take Cialis, a very strategically chosen drug, out of the contract pharmacy distribution channel, that we're also seeing that Merck has also taken steps to try to limit its exposure to 340B program utilization through the contract pharmacy route to the covered entities. So Merck sent a notice to covered entities requiring that they share contract pharmacy claims data for Merck products through Second Site Solutions 340B ESP platform beginning on August 14th. And we expect that this is going to continue to be an issue that Merck and other manufacturers are going to be pursuing. And so it will be interesting to see how both sides of this issue continue to allow their position vis-a-vis the other to evolve. Merck said that the request is part of a new 340B integrity initiative, and that the claims data uploaded to Second Site Solutions platform will be used to identify and resolve duplicate Medicaid and commercial rebates. So this is an interesting question. The idea here is that what they're looking for is less so about diversion and more about whether or not there are claims for 340B pricing in this for the same utilization where there may very well be Medicaid utilization as well. And the statute is very clear that you cannot have double dipping, so to speak. And so once it is determined that there may be some of this double dipping utilization, then Merck is going to have the opportunity to either challenge the states through a process in the Medicaid drug rebate program and try to claim those rebates, or it may try to go back to either the contract pharmacies or the covered entities to figure out what's going to happen. So only time will tell how that really plays out. Notably, although Merck has indicated the use of this ESP platform as being voluntary, its notice to covered entities emphasizes that absent significant cooperation from covered entities, Merck may take further action to address 340B program integrity. And Merck specifically notes that such action may include seeking 340B program claims information in a manner that will be substantially more burdensome for covered entities. In a recent letter, it should be noted, a coalition including 340B Health, the National Rural Health Association, the National Association of Community Health Centers, and the National Healthcare for the Homeless Council, among other groups, is asking the Department of Health and Human Services to prohibit Merck from imposing substantially more burdensome requirements should covered entities not voluntarily share the data that's been requested. The letter also touches, not surprisingly, on Eli Lilly's notice, urging that the department intervene and arguing that its actions violate the 340B statute's requirement that manufacturers must offer 340B prices to eligible covered entities. They note that no provision in the statute allows manufacturers to limit 340B pricing in this regard, or require that a drug actually be shipped to a manufacturer-approved location once HRSA has already added that location to the OPAIS database.
Thank you, Andy. And finally, we wanted to provide you with an update on 340B legislation that has been recently introduced as a means to provide relief to 340B hospitals, mostly as they continue to respond to the current COVID-19 pandemic. As you know, to participate in 340B program, disproportionate share hospitals, freestanding children's hospitals and cancer hospitals, full community hospitals, and others must demonstrate a minimum disproportionate share hospital, or DSH, adjustment percentage on their most recently filed Medicare cost report. Hospitals whose percentage falls below the minimum are not allowed to participate in the program. As COVID-19 continues to spread across the country and hospitals have been assessing the long-term financial impacts of the pandemic, hospitals participating in the 340B program have expressed concerns about how changes in admissions and payer mix related to the pandemic could impact their long-term 340B eligibility. There are concerns that some hospitals that have increased their bed capacity to accommodate an influx of patients could fall below the minimum threshold, which could impact their long-term eligibility. As a result, 340B hospitals and other provider groups, including 340B Health and the American Hospital Association, have been advocating for HRSA to waive the DSH adjustment percentage eligibility requirement, given HRSA's stated position in recent COVID-19 340B guidance that it is unable to waive statutory requirements, such as the DSH percentage. 340B hospitals and their trade groups have been requesting Congress to address the issue legislatively. And as you may know, when we reported in a previous episode of Triage, Senator Ben Sasse from Nebraska made an early attempt to incorporate a 340B eligibility amendment to the CARES Act, the $2 trillion coronavirus relief package that Congress passed in March. Although the amendment was not ultimately incorporated into the CARES Act, given in part with which the urgency with which it was passed, 340B hospitals and their trade groups have continued to work with Congress in this month to try to seek a potential statutory fix. Most recently, Senator John Thune, who serves as Senate Republican whip, recently introduced the bill to pass 340B eligibility requirements during the pandemic, with the hope to incorporate it into Congress's next relief package. We understand that the bill would ensure that any previously eligible hospital would be deemed eligible for any cost reporting period during which the emergency occurred. Senate Republicans are expected to release a draft of their COVID-19 relief proposal as early as this week, which they hope to approve before August. This draft will serve as a starting point of negotiations over the next COVID-19 relief legislation. Although it isn't clear at this point whether the 340B language will be included, we do expect Senator Thune in his role to play a key role in negotiations over the next COVID-19 relief package. Thus, whether it is ultimately included will likely depend on how targeted the overall measure is and the need to address other priorities as part of this package.
We'll go ahead and wrap this triage up, but we do note we'll continue to monitor these developments closely as we have done these many years, and our healthcare and FDA practice and policy groups continue to regularly work with various 340B program stakeholders on a variety of matters, and will continue to be available to assist in this, as Andy, you helpfully pointed out, incredibly dynamic moment in the 340B program. So thank you again for listening to this episode of Triage on recent developments in the 340B program, and please do not hesitate to contact us if you have any questions.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.